Bueno, buenas tardes. Damos comienzo a este webinar organizado por la Asociación Colombiana de Retina y Vitrio, Fundonal y la Sociedad Panamericana de Retina y Vitrio. Contamos con una serie de expertos de Asia en el manejo de enfermedades maculares asociadas a patología coroidea. Entre ellas, este programa en el cual empezará a hablar el doctor Chablani con dos temas de coloretinopatía central serosa, la primera, membranas neovasculares coroideas secundarias a central serosa, y la segunda, enfermedades que pueden simular una coloretinopatía central serosa. Luego la doctora Jenny Chung nos presentará una charla sobre las imágenes multimodales en la fisiopatología de la vasculopatía polipoide coroidea. Y finalmente el doctor Adrian Ko, también de Singapur, nos hará una presentación sobre el tratamiento actual de la vasculopatía polipoidea. El doctor Li Wu muy amablemente participará como moderador de la sesión de preguntas y respuestas. Una breve introducción de nuestros speakers. En primer lugar, el doctor Adrian Ko de Singapur, quien hizo su entrenamiento en retina médica en el Merseyside Hospital y el Instituto de Oftalmología en Londres, al igual que otro fellowship de retina médica en el Jules Stein Institute de la Universidad de California en Los Ángeles. Actualmente reparte su tiempo entre la práctica clínica privada y la pública. En la privada hace parte de un grupo de retina muy grande en Singapur, en el Camden Medical Center, y también participa como consultor del servicio de vitro y retina del Centro de Ojos Nacional de Singapur, del Singapore National Eye Center, y también participa de las actividades del Singapore Eye Research Institute. Ambas entidades las maneja Jimmy, quien es su jefa. Su investigación ha estado más en retina médica y es conocido por su participación como investigador principal, y además como quien ha sido el autor de las publicaciones de los estudios Everest 1 y 2 para el manejo de la PCB y también del estudio Review. Ha recibido numerosos reconocimientos, entre ellas ser presidente de la Sociedad de Singapur la Sociedad de Oftalmología de Singapur, es miembro del Comité Ejecutivo del Colegio de Oftalmólogos de Singapur y también hace parte del Consejo Directivo de la Academia Asia-Pacífico de Oftalmología y de la Sociedad de Vitro y Retina Asia-Pacífico. Fue el fundador de la Sociedad de Retinitis Pigmentosa de Singapur y actualmente es el director ejecutivo para SASO de Asia. Es miembro de la Macular Society, del Club Jules Gonan y también de la Vision Academy. Jimmy, que aunque usted la verá muy joven, pues ha desarrollado una fulgurante carrera en oftalmología, luego de realizar sus entrenamientos de fellowship en el Royal College of Ophthalmologists en retina médica en Wolverhampton Eye Institute y también en Uveitis en Birmingham and Midland Eye Center. Ha recibido numerosos reconocimientos, entre ellos el de la prevención de ceguera de la Asociación Asia-Pacífica de Oftalmología, el Nakajima Award de la Asociación Asia-Pacífica de Oftalmología, también de investigador más joven de la Macular Society, premio de la Academia de Americana de Oftalmología y la conferencia Young Constable de la Asociación Asia-Pacífica de Retina y Vitrio. Actualmente se desempeña como profesor del consorcio de la Universidad de Duke y del National University of Singapore Medical School en Singapur, y es la jefa del Departamento de Retina Médica del Singapore National Eye Center y también la jefa del grupo de investigación en retina del Singapore Eye Research Institute. Hace parte también de la Macular Society y de la recientemente creada la International Retinal Imaging Society. Finalmente, Jay Chablani, ya conocido por algunos de ustedes en los preceptorships que organizamos, hizo su entrenamiento en retina y vitrio en Chennai, luego realizó su entrenamiento de fellowship a través de ICO en el Hospital Jules Gonan en Suiza, y finalmente un entrenamiento en San Diego, en el Jacobs Retinal Center and Shield Eye Center. Posteriormente regresó otra vez a trabajar a la India, pero desde hace un año se desplazó a trabajar a la Universidad de Pittsburgh, donde está desarrollando su trabajo en retina médica. También ha recibido como reconocimiento la conferencia magistral Young Constable de la Asociación Asia-Pacífica de Retina y Vitrio, e igualmente la conferencia magistral de joven investigador de la Sociedad India de Retina. Sus intereses son principales en enfermedades maculares en imágenes diagnósticas y sobre todo en coroides. Tiene más de 300 publicaciones y ha sido editor de 2 libros de coroides, como son el de enfermedades coroideas y el de la coroidetinopatía central serosa, de la cual es un experto mundial. Por lo tanto, participa como revisor para en múltiples journals de oftalmología, siendo ya parte del board del American Journal of Ophthalmology. Hace parte también del Global One Network Committee de la Academia Americana de Oftalmología y recientemente ha ingresado a la Macular Society. Y nuestro amigo Lee Tewu, conocemos hace mucho tiempo con una también brillante carrera en oftalmología, sobre todo en retina y vitrio. Hizo sus estudios en Tulane, luego de haber hecho sus estudios primarios en la Universidad de Cornell. Estudió medicina, como decía, en Tulane, donde por su desempeño pues, fue galardonado con el Peer Research Fellowship. Posteriormente hizo oftalmología en Mount Sinai Medical Center en Nueva York y luego hizo su entrenamiento en retina y vitrio en el National Retina Institute en Baltimore, donde desarrolló una impecable labor. Ha desempeñado múltiples posiciones, ustedes lo han visto como directivo en la Academia Americana de Oftalmología, también como directivo de la Asociación Panamericana de Oftalmología, de la Sociedad Panamericana de Retina y Vitrio, donde desarrolló gran labor como presidente. Ya recibió también reconocimientos por parte de la American Society of Retina Specialists, de la Greek Retinal Society, de la Academia Americana de Oftalmología y de Pacores, donde ha sido miembro fundador. Hace parte también del Club Jules Hunan, de la Macular Society, de la Retinal Society y de la Vision Academy. Entonces, sin más preámbulo, vamos a dar comienzo a nuestro cuadro, dándole el paso para que Jay Chaviani pueda hacer su presentación. Adelante, Liti.
Jay, go ahead, please.
Oh, that was quick, Lite. Thank you so much, Dr. Rodriguez, Lite, for giving me the opportunity to speak. I have been to Bogota last year as well, I think before as well, and I missed the opportunity of seeing you all in person, but at least virtually. And I'm happy that I'll be sharing the symposium with very close friends, Jamie and Adrian. So let me get started with my CSR CNVN topic. And are you able to see my slides?
Yes.
Perfect. So without spending much time, I'll start speaking on CNVM associated with CSCR, which is becoming a more and more prominent and known entity. And now we are able to diagnose these diseases much easier and then treating them as well very well. So these are my financial disclosure. I do not have any financial disclosure with this presentation. CSR CNVM, it usually presents in older patients. The previous literature says that it ranges from 2 to 9% in cases with chronic retinal pigment epitheliopathy. However, this data is from the age when OCTA was not available, and we'll be coming to that in more detail eventually. Primary pathology behind the CSR CNVM is chronic decompensation of the RP and the disruption of the Brooks membrane, which is the proposed mechanism. And we have experienced that this disease presents mostly in chronic RP epitheliopathy patients, and we'll be seeing some of these examples as well. However, this is something which I feel is very important, that CNVM in a CSR patients mostly is because of the CSR. However, you may be able to see these CNVMs secondary to some treatment which was done before, primarily a laser or a PDT induced CNVM, and as it was seen in one of my patients, as you can see on the picture, that this patient had a CSR laser for 2 years before, and he came with a subretinal hemorrhage and exuded, and we could actually track down the feeder vessel, the origin of the CNV, very close to the laser scar which was done previously. However, the incidence of secondary CNVM in CSR is very less. This is only 0.6 to 5%, and it used to happen more often with the previous conventional lasers. However, the incidence of CNVM secondary to laser with subthreshold is not reported so far. So we believe that subthreshold laser is much safer. However, the conventional laser is something which we are still using for CSR. Let's move on with the imaging features of the CSR CNVM. Fundus autofluorescence, as I already mentioned, that CNVM happens mostly when we already have chronic RP changes. As you can see here, these changes on autofluorescence tells you that this disease has been, CSR has been existing for a really long time. You may be able to see a diffuse RP changes, RP tract, all the features of chronic CSC could be present. However, we still may not be able to see any specific signs of CNV on the fundus autofluorescence, what you expect in AMD CNVM, just because of the pre-existing widespread RP changes which are already there. What about fluorescein angiography? Fluorescein angiography shows early hyperfluorescence with ill-defined late staining. Honestly, it is not very helpful, but you can see that this is a punctate hyperfluorescence which is seen and slowly leaking. You really have a lot of challenge in diagnosing CNVM on fluorescein angiography even in today's day. But ICG definitely supports a little bit, but the literature supports that the ICG can diagnose only up to 25 to 42% of the CSR CNM cases, and you have to be really lucky, as we were in this case where we could actually see a type 1 network on ICG, and you can see that the parallel picture on the left side of fluorescein angiography does not show any network. Let's move on to OCT, which is the most common modality which we use. These patients will have a usual signs of CSR as we expect: a shallow SRF, retinal pigment epithelial detachment, intraretinal fluid is also possible. You may be able to see the cystoid macular degeneration changes or RP atrophy. However, if you really look at these features, you can still not be sure that whether CNVM is there or not, because these features can be there even without CNV. So what actually pushes you towards the diagnosis of CNV is this flat irregular PEDs, which are sometimes called as double layer sign when we talk in context of PCV. However, whenever you see a FIPID like this, then you should be suspecting that there could be a CNV. And we'll come to the details about the FIPID eventually. And very rarely, it is possible to have a type 2 CNV with CSR, as you can see in the bottom picture, but the top picture of FIPID is very, very common in patients with CSC, and we'll come to the details. How do we actually move forward? Let's talk about OCTA, which has actually changed the whole understanding about the CSR CNVM. The diagnosis of CNVM in CSR has increased tremendously, ranging from 30 to 95%. With the help of OCT angio, you are able to now detect the CNVM at much early stage. And I like to use OCT angio when, especially when you're following up these patients, in particularly with CSR. So let's look at one of the OCT angio pictures of FIPID from one of my collaborator, Marco Lupidi, who contributed one of the chapters in my book. So if you look at this picture, you will see that the fluorescein angiography does not show much of the changes. Neither does the ICG in the middle panel shows any obvious CNVM, and the OCT also does not show anything. It just shows a subretinal fluid. You, by looking at that OCT scan, you would not suspect there is a CNV. However, if you get an OCT angio here, you are seeing that there is a small network which is extrafoveal. And the reason you missed that, because your scan which you got on a printout was only passing through the fovea. So when you see an en-face view of the OCT angio, you will see that there is a small network, and I'll just show you where exactly the FIPID was present, which we missed, which was extrafoveally. Just look at the left, the yellow arrow, you will see that there was a shallow pigment epithelial detachment, which actually was harboring this CNV complex. Let's move forward and talk a little bit about the reflectivity of the FIPID. As I said, this is one of the very important signs. If you look at the top image, you are seeing that the flat irregular PD has some reflectivity within it. Under the PED, under the RP, you are able to see some hyperreflectivity. However, in contrast, you will see that the bottom picture, the, the, the irregular PED has a hyporeflective content. You do not see any hyperreflectivity. And now let's look at the OCT angio, which is present on the right side of the panel. You will see that the top image, which had the hyperreflective FIPID, has OCT angio, has CNVM on OCT angio, but the bottom picture, which is a hyporeflective FIPID, does not show any CNV complex on the OCT angiography. And this is how you need to approach and think about your patients. How do we actually use OCT angio in follow-up? This is one of most interesting cases I have ever seen. This is the 67-year-old female who came to me back in 2013 when we did not have OCT angio. She came with a shallow subretinal fluid in both her eyes. I got her ICG and I could suspect that CNV complex is present. I performed a PDT and she did really well. And you can see that the fluid is completely gone. The RP atrophy is there in the center, but it never had any issues after the PDT, and she was on a regular follow-up with me, and she was really doing well, except that at almost 3 years after her PDT, she came in the left eye with a uh, subretinal fluid, I would say massive, because it was like really unexpected visit where she had the vision loss associated with this subretinal fluid, some content in the subretinal space, pretty exudative kind of disease. Then I went ahead and got her OCT angio, and I'll just take your attention to this picture where you can see that there is two differential reflectivity of the CNV network. You can see that the network which was behind, which is in the deeper side, is clearly seen much lighter, and the complex which has actually broken the RP and come in the subretinal space, you can see that this is a type 2 component which is much brighter. And this was something which I really learned from this case, that OCT angio, you can actually just doing this OCT angio, you can follow up these patients, and where you can actually look at this network. And this later we published this case report, and this patient again underwent an anti-VEGF injection, and you can see that how she has responded so well with anti-VEGF injection. And you can see that the type 2 component has actually regressed, and the type 1 network which was there even after PDT is still there. However, the type 2 is completely gone, subretinal fluid is gone, and now we were reassured that, okay, this patient is doing really well, and we stopped the treatment and kept her on follow-up. This was one of the interesting things which we found in one of our papers where we looked at the OCT angio of cystoid macular degeneration patients, as we always struggle with these patients that they do not respond to any treatment, and you have tried everything, and many times you will see that they don't respond to anything. And we performed OCT angio in these patients, and we found that almost 44.8% of these eyes had CNV network. So since then, I believe that these cystoid macular degeneration, which we consider them as non-respondent disease, they may be having a CNV complex under them, and we can consider doing PDT in these patients, and they may actually stop leakage in this way. So as we saw, multimodal imaging is the key, and this is one of our one of the patients from my book, where we can see that you have all the imaging modalities present. On the top panel, you can see that the dye-based angiography is not helping us much in actually identifying the CNV complex. You can see that the top right image of ICG in the late phase does show a lot of leakage, which goes well with the CSR, that is a diagnostic. However, if you look at the bottom image where we can see the OCT angio clearly showing you the network, the OCT B scan showing you a subretinal fluid with a FEPAD, which is again a hyperreflective, again suggestive of having a network underneath. This is another example where we can again see that the fluorescein angiogram, the ICG is showing diffuse leakage, but the network is still not very distinct, which is clearly seen on the OCT angio, and the OCT does show a FEPAD with hyperreflectivity underneath. What about the fellow eye? This was again something which I was interested in, that to understand how does the fellow eye do of the patients with CSR CNVM. As you can see in this case, the fellow eye does have a FEPAD, which is hyperreflective. It does not show any network. However, I will show you another case of a fellow eye. You can see that the right eye does show an obvious CNVM in presence of CSR. The left eye on the right side, you will see that the fluorescein angiography just showed a punctate leakage. The OCT did show a flat irregular PED, but the OCT angio made it very obvious, the network, even in the fellow eye, which was asymptomatic, and as well as there was not any much of SRF, or we wouldn't have suspected this on conventional imaging. So what we learned is that 1/4 of these fellow eyes showed some amount of vascular network which we could not diagnose on conventional imaging. So the message from this slide is that you need to have the OCT angio of the both eyes, even if you are not suspecting any CNVM in the fellow eye. What about outer retinal tubulation? This is something which recently got accepted, where we showed that these outer retinal tubulation can be present in patients with CSR CNVM, because this entity has been described in various CNVMs as well as in dystrophies. But we were interested in looking this ORTs into this disease, and this is one example. This is another example of ORT in CSR. What we learn about ORTs in CSR CNVM is that they are less frequent. However, when they are present, they are innumerable number, because just because the RP atrophy is much more diffuse compared to the AMD CNVM, that's why you tend to have more ORTs. They are mostly extrafoveal. They are more in spheroidal shape compared to the AMD CNVM, and you can see some of these examples. This is something which we very often we get a question that when do you actually suspect a CNVM? Because many times you are treating your CSRs and you are not able to understand that why this patient is not responding to any treatment. So I just tried to list out some of my experiences while I missed the CNVM when we start treating our patients in conventional way, focal laser or Eplerenone. You could not do PDTs and the patient is still not responding, then you should suspect that there could be a CNVM hiding somewhere. Or if you actually are dealing with a non-resolving cystoid degeneration where the cysts are not going, and you are thinking it is a chronic CSR, however, there is a CNVM underlying there. And as I already said, that if you suspect a FEPAD which is enlarging or the reflectivity of the FEPAD is changing. So what about the treatment? This is something which we published long back, that anti-VEGF is the treatment of choice with or without PDT when you end up diagnosing a CNVM with CSR. However, we as stands true for the other non-AMD CNVMs, you require less number of injections. People have tried treating these CNVM with Eplerenone or subthreshold laser, but the success is not really great. So with this, I will conclude that CSR CNVM is an important cause for vision loss. It is actually one of the very common cause for poor response to conventional treatment. So you need to have a red flag as soon as you feel that the patient is not responding to your treatment. The multimodal imaging, as I showed you in many ways, it is really useful, especially now OCT angio is must. And do not ignore any shallow irregular PD if you are seeing on a structural OCT, because many years before we were taught that, oh, every CSR has a shallow PD, just don't worry. But if you really see a shallow irregular PD, you need to think that there could be a CNVM. And as we saw, that anti-VEGF and the PDT are treatment of choice. Most of this I opted from my book in Central Series, and we have a nice chapter on this. And with this, I would like to acknowledge LV Prasad, where I did a lot of this work, and acknowledgement to the great institute. And thank you very much for your attention.
Thank you, Jay. So my boss, Dr. Rodriguez, says that we should go on and take questions at the end. Okay.
Okay. So you want me to speak for next 20 minutes again?
Yeah.
Okay. All right. Okay. Give me a few seconds. Okay. So this is a much more interesting topic. And I'm just going to share my, okay. Are you able to see my slides now?
No, they were here for a second and then they disappeared.
Oh, okay. Now?
Yes.
Is it good? Oh, perfect. I'm sorry.
Yes.
Got it. All right. So I'll be talking about CSR masquerades, and these are my financial disclosure, and I have no financial disclosure with this presentation. So let's start with a case of a 27-year-old male who came with a vision loss of 2200, where you can see that the subretinal exudates, probably some subretinal fluid on this. And we got the OCT. OCT shows subretinal fluid, and as we saw, fibrin is there. So we suspected a CSR, and I asked for a OCT, fluorescein, and a fluorescein showed a pinpoint leakage, which was having a typical CSR leak and very typical ink blot. And we treated this patient with the micropulse laser to the subfoveal leak, and this fluid resolved and everything is okay. So you guys must be suspecting that there was no suspect. Okay. So with this, we move on to the next case of a 36-year-old male who had the subretinal exudates, as you can see here, with the subretinal fluid. And he was sent to me, he came for a second opinion. He already, this was his left eye. He already got his fluorescein angiography as well as OCT elsewhere. And the doctor diagnosed this patient as CSR, and he asked nothing to do and just observe. And this is the fluorescein angiography where you can see the pinpoint leakage, which is increasing. And yes, it definitely looks almost similar to the last case. However, I was not very satisfied with the OCT which he got elsewhere. So I told him that let me have a look at the volume. So let's get an OCT done. And we got his OCT done, which showed subretinal fluid. But as you move forward, you will see that there is a CNVM, which I diagnosed as idiopathic CNVM, and this can confuse you with CSR, and this patient needed an anti-VEGF therapy instead of observation on focal laser. So the message from this case is that whenever you suspect CSR or something subretinal exudates, you need to go and look at all the OCT scans of the volume, and be very careful when you are looking at the fluorescein angiography. Let's move on to the second case of 51-year-old male, and this case also came back in 2013 to me. He came to me with a decrease in vision in the left eye for last 20 days. He was diagnosed elsewhere as multifocal choroiditis and was started on oral steroids. This was his right eye of 20/60, where you can see the RP changes. They are more like a pigmentary changes, and the pigmentary changes are present on the nasal side of the right eye as well. The left eye was a little bit more scary, where you can see these subretinal exudates. The fibrin is down there near the inferior arcade. There was RP changes, pigmentation, the exudative fluid inferiorly, and the left eye had exudative detachment. I kept as a differential of chronic CSCR, multifocal choroiditis, and VKH. I got his OCT done, which showed subretinal fluid, cystic changes, and you can see that PED is there in the left eye. I got his fluorescein angiography. Still now, I was very confident that yes, I'm dealing with a CSR. But fluorescein angiography was more scary. You can see that it has a pinpoint leakage, multiple changes, and the disc is also leaking. You can see the peripapillary leakage. The left eye had multiple leaky spots with this punctate leakage, as well as you can see the disc is also leaking. And this is where I really got worried that am I really dealing with a choroiditis with the disc leakage. Then I said, okay, let us get the ICG. ICG did not help much, where you could just see the filling, and the ICG was okay. There was some leakage, which is possible even in VKH. But I still made the diagnosis of chronic CSCR because my gut feeling was that yes, it is probably is CSR with the exudative detachment. I stopped steroids, called him in a week time. He comes back in a week time doing well, 20/40, 2200. The right eye is, you can see at 1 week, it is already showing the signs of resolution. The OCT is looking much better. The fluid, intraretinal fluid has come down, but the subretinal fluid is still there. The left eye also showed the fibrin is now becoming settling inferiorly just below the fovea, and you can see that the OCT is slightly better. So I told him that let's do the focal laser to the possible lasers. We did Nevilas laser at that visit. We called him in 2 months, but he comes back in a month's time and complains of further vision loss in the left eye. And I saw that the exudative RD has progressed and the macula is is now off. So I took him up for the left eye subretinal fluid, and I decided that it is CSR. We went ahead and did a PDT. We did the subretinal fluid drainage using chandelier. We went ahead and did a half fluence PDT after 1 week, and you can see that 3 months after PDT, the right eye is to 20/25, which was 20/60 with so much of fluid and intraretinal fluid. The left eye is also looking much better compared to the baseline picture at the bottom. The patient is doing really well, and I followed up this patient for 5 years. He had a CNVM in the left eye, and then we treated with anti-VEGF, and he did really well. So with confidence, I can say that at baseline, it was a CSR after 5 years. Let's move on with the next case of a 63-year-old male who was referred to me as a CSR, where you can see a subretinal fluid and few hard exudates there. The OCT did show a subretinal fluid. However, when you look at the different scans of the OCT, you will see that there was something which was bothering me just above the fovea, and we got the OCT angio, and it made a very simple diagnosis of a RAP lesion, which was clearly standing out on this OCT angio scan, and this is what was seen on the OCT, and this patient needed anti-VEGF therapy. Let's move on with the next case of a 35-year-old male was diagnosed as CSR, came for a second opinion, and we see that subretinal fluid is there, some intraretinal cyst, and this patient was told that you may require PDT. So he came for the diagnosis of chronic CSR. This was the fundus picture, some RPE changes, and this was the OCT. And when I went to look at the device, I ended up seeing this bulge, which was not, this was a scan which was not printed for me. And I see that there is a bulge in one of the scans along with the subretinal fluid. And now I'll just show you, just look at the infratemporally, there was a choroidal hemangioma on the B scan, and you can see it clearly. We got his fluorescein, which confirmed the signs of choroidal hemangioma, and we referred him to the oncology. This was the case of a 56-year-old male who came to me with a poor vision in the left eye since 3 months. It was 20/20 in the right eye. The right eye autofluorescence show almost typical features of few hypo autofluorescence spots. The left eye showed some changes, not much, but autofluorescence showed these hyper autofluorescence changes, probably because of the chronic fluid. And we got the fluorescein angiography. Did not show any obvious leak, but it was like looking like a chronic CSC in both eyes. I got his OCT. On those days, we did not have OCT angio, and this was the right eye, as you can see. The left eye had a sign of CSR, where you can see a subretinal fluid, these hyperreflective dots, as well as a small PD temporally. So I did the micropulse laser for this patient. Patient could not afford PDT. I called him up in 3 months, and you can see that the fluid is still there. I put him on Aptus, and I called him in 2 months' time. And he comes back after 2 months' time. The CSR is still persisting. Patient is already taking Aptus. He has not responded to anything, and his vision is 20/30. So I bumped into his complete scan. On the top image, you can see it's a horizontal scan which shows a subretinal fluid, and the bottom scan clearly shows a dome or a staphyloma, where you can see that the curvature of the choroid is suddenly changing, and you can see that the subretinal fluid is in that area. These were the days where we were not much aware of the dome-shaped maculopathy. I saw his left eye. Left eye also has a typical signs of a dome or a staphyloma. There was not a clear-cut dome, but I diagnosed this case as a staphyloma-induced maculopathy in the left eye. And we all know that these patients do not do really well with whatever treatment you offer. Then I had to, and the good part with this disease, what I have learned in last couple of years following up these patients, they usually don't lose much vision as well. So they remain in the range of 20/20, 20/30, and we decided to observe this patient. Let's move on to the next case of a 40-year-old female who came with a history of vision loss for last 2 years. And you can see these some yellowish deposits, some changes in the both eyes. I got her OCT done, and OCT does show subretinal fluid, and you can see these hyperreflective dots, very typical signs of CSR. However, when you look at the autofluorescence as well does show a lot of chronic RP changes. However, you can see in the peripheral part that there are these hyper autofluorescence deposits which are actually bordering the area of the RP atrophy. And that is where I started suspecting a best dystrophinopathy, and we got her uh, uh, EOG done, which showed false positive. However, you can see that the responses are really reduced, and we diagnosed this patient as Best dystrophinopathy. Another case of a 30-year-old male who came to me with a diagnosis of CSR. Patient vision in the left eye was 20/100. The OCT shows clearly a subretinal fluid with some deposits. However, when you get a fluorescein angiography done, you will see that there is not as such a focal leak. However, there is a diffuse hyperautofluorescence, and that is why this is not CSR, but it is a syphilitic posterior placoid choroidal retinitis. And we put him on benzyl penicillin, and this patient after 2 weeks had the resolution of the placoid lesion, as well as the OCT became absolutely all right, along with the resolution of the fluid as well as those deposits. So with this, I will just take you to some of the algorithms which we made in some of our publications and for the book chapter, where this was the algorithm which we published in survey. If you have a patient with subretinal fluid, I'm not going to go into the details of this algorithm because I believe I have already crossed the time. So you can go and look at these charts in the publication. If you have a subretinal fluid, how does the subretinal fluid looks, whether it is yellowish, heme, optic disc, and if you then you look at the periphery, vascular changes are there or not, or if there is a choroidal bulge, or there is a exudative detachment. So this algorithm clearly shows that how do you actually approach your patient with CSR, and how do you actually reach to a right diagnosis when you see a masquerade. And when we were working on this manuscript, we came up with another idea which we published later in the book chapter, which I wrote for my book, where we actually looked at that how do you actually approach your patient with CSR, that by looking at the color photographs, what do you see on color photographs, what do you see on OCT and on ICG and different imaging modalities, and by ruling out each of these factors, you may be able to reach to the correct diagnosis. So I just recommend that if you have interest, you can go through two of these contributions. One is the paper in the survey and the chapter in my book on the masquerade, and these charts you will be able to easily find it. With this, I would like to acknowledge LV Prasad, where most of the cases are from that place, and thank you very much for your attention, and apologize if I crossed the time.
Jay, that was great. Okay, can you hang on with us?
Oh yeah, definitely. I have taken permission from my wife.
Okay, so we're gonna go with Jemmy. Jemmy, are you ready?
Yeah. Good morning. My name is Jamie Chan. I'm from Singapore. I'm very glad to have the opportunity to join you all. And once again, thank you to Francisco and Lite. Except that my screen has paused. Can you still see me?
Yes.
Okay. I'm going to share my screen now.
Yeah.
I think that's what I need to do. Except I want to put it on slideshow. Okay. Can you see my screen? Can I check?
No, not yet.
No? Okay.
No. Okay.
Yep. Okay. Now,
yes.
Okay, still working, yeah?
Yes.
Okay, great. Okay, thank you very much. So this morning, I've been tasked to talk a little bit about imaging in PCV. So I've decided that I would talk about three main modalities. First is OCT, and I will spend more time on that. Second is a little bit on OCT and geography. And finally, just to finish off with our gold standard, which is ICGA. So already you can see that the order has kind of changed from traditionally we generally say ICG is the gold standard. So of course, ICG, we know there are some limitations. We are all familiar with beautiful ICGA demonstrating the bulbous dilatations and the branching vascular network, the two main components of PCV lesion. And it gives us a movie as well, so we can see the dynamic filling properties. So those are all beautiful images, except that ICG, as we all know, is not cheap, is not simple, is invasive. Whereas most of us will have easy access to OCT. So we start to ask, can we start to look at OCT to diagnose PCV, and how in comparison to ICGA? So already we know that since many years, so this is a paper from 2007, for example, demonstrating several individual signs. For example, like Jay has mentioned earlier on, what we now call a shallow irregular RPE elevated or double layer sign is often where we harbor a type 1 MNV underneath there, and we could have a PCV lesion in there. Separately, you can also look at the en-face imaging, and here you can see the outline of the PED, as well as, again, the complex PED shape of the PCV complex, and within some of these PEDs, we can see the polypoidal lesions as well. So these are looking at individual signs. Subsequently, quite a few groups have discussed using a combination of signs. So for example, this paper looked at an elevated orange-red nodule on the color, a double layer sign, as well as a high dome-shaped PED on the OCT, and they reported quite good performance of this set of criteria. Another paper, quite similar theme, a lot concentrated on the shape of that PED, complex shape, sharp peaked PED, notch in the PED, etc. And in addition, this paper mentioned if you see a round sub-RPE little ring like that, that may be where the polyp is. Again, combination here, this paper suggested using 3 out of 4 of those signs. And another paper, again, very similar, suggesting a combination 2 out of 3 of PD double layer sign and this thumb-like polyp as well. More papers along those lines, and if you have time, you can read in detail what are the signs down at the bottom here that they used to look at. In addition to those, okay, so we've now more recently become more familiar with a couple of other features which are often associated with PCV. One is a thick choroid or pachychoroid, as you can see here. We can use enhanced depth imaging or swept source OCT to appreciate the thickness and the dilated Haller's vessels here. And another feature is using the en-face, which hasn't been looked at very carefully, in combination with all those signs, and perhaps en-face OCT angiography as well. So I think the limitation with en-face imaging is that previously we are generally more familiar looking at the cross-sectional OCT, whereas nowadays, because many of us are learning to use OCT angiography, and inevitably our familiarity with en-face OCT as well has improved. So this is a good time to examine this combination. So I've had the great opportunity to work with a group which was formed under the auspice of the APAO. This is called the AP Ocular Imaging Society, and Jay is one of the panel members, and Adrian is one of the panel members. So we started this group, and the main agenda initially is to propose inclusion of OCT features as diagnostic criteria for PCV, particularly for settings where you can't easily access ICGA. We're not saying we'll replace ICGA. You can access it very easily, but sometimes you don't have a choice. So in those cases, having something is better than nothing. So this is the group of panel members that we work together. These are some of the meetings that we had together. And the first question we ask is, do the panel members feel that in the absence of ICGA, do you think it is now time to use a combination of non-invasive features to sufficiently make a probable PCV diagnosis? And I was glad to say that maybe times have changed, our understanding of all these imaging modalities have changed, and the unanimous answer was a yes. And therefore we went on to say, okay, if that's the case, which are the OCT signs or the combination of OCT signs, and let's look at them in detail. So we went through a few exercises. You've seen the literature review I showed you just now. Many individual signs, and I've listed some of the key ones here, 11 signs, have been described individually. And we listed them out. We looked at many examples, and we say, okay, in your mind, which of these is a PCV? And if you then dissect the individual signs, which are the signs that made you make that diagnostic decision? Okay, so you can see some of these sharp PED, there is a ring here, there's dilated vessels, there's SIRE, shallow irregular RPE elevation, etc. And also on color as well, you may see a red nodule. So then we shortlisted out of those 11 signs, 9 key features, 2 based on color fundus photographs, extensive subretinal hemorrhage, orange nodule, as well as 7 signs based on OCT, a sharp-peaked PED, and these are some of the examples here. Sub-RP ring-like lesion, such as this one, and sometimes you can have the same signs or multiple signs exhibited in one eye. So for example, here you've got the sharp-peaked PED together with the sub-RP ring, which makes it actually very likely to be a PED. Then you can have complex multilobular or notched PED, a double layer sign, a dilated Haller's vessel or pachychoroid, a particular fluid compartment concentrated on subretinal fluid as compared to intraretinal fluid, and finally the en-face OCT, which shows you the outline of a multilobular or complex PED. So these are our outline signs, and we then went on to test in a masked fashion 20 cases of mixed proportion of PCV and non-PCV cases. So this is one example, and each panel members was given this kind of images of the cross-sectional OCT, the color fundus photograph, and also the en-face image. So here we give them the whole fly-through instead of cutting through, so that individual panel members can look at the relevant cut themselves. Okay, so never mind about this rather complex table, but I would just like to draw your attention to the top 3, which are in green here. These are really the highest performing 3 signs with AUC of about 80 for individual signs. And these are the sub-RP ring-like lesion at the top, the en-face OCT showing complex RPE elevation, and the sharp-peaked PED. So at the bottom, these 2 in red did not perform very well, meaning that you look at the specificity. Although we know that massive hemorrhage can be a presentation of PCV, but this is not very specific. Similarly, subretinal fluid could be PCV, but could simply be a type 1 MNV as well. So we decided we will not include these 2 signs. So what if we combine 2 out of 3 of these individual top 3 signs? Can we perform even better? And you see that particularly if you have a combination of 1 and 2, you get an AUC of almost 90%, and this is quite a specific combination. 9 out of 10 times you'll be right for diagnosing a PCV. So as such, we went through the validation of almost another 100 eyes based on this choice of 2 out of 3 of those signs, okay? And then we concluded that this will give us an AUC of almost 9 out of 10. And we do recommend that if you don't have easy access to OCT, that is an easy way for screening purpose. Either you say, okay, if I'm now suspecting PCV, I'll do something different. I will send this patient to an ICG, or I would change my choice or regimen of using anti-VEGF, or I will simply make a note in my case note to say, okay, we'll try anti-VEGF monotherapy, but keep a higher suspicion that if the initial response is not adequate or not optimal, then I may think again at doing the ICG at the 3 months. So those are some of the applications we recommend for using this set. And that is on the OCT. Just to show, let me see if this video is, okay, so it's a bit jerky. Okay, here's just to review some of those signs again, using the en-face OCT showing quite clearly the PCV complex, and in combination you can scroll up and down on the cross-sectional OCT to look for those PED signs. Another example again of en-face, and you can see the sharp peak PED in the cross-sectional as well. Okay, so now then with that we'll move on very comfortably from the en-face OCT to the OCTA. how much does the OCT angiography component add to the OCT? And here you can see that actually the en face itself is not bad. You can really see the outline of the PCV complex. You can see the outline of branching vascular network, and where the big PEDs are, you can suspect that's where the polypoidal lesions are. And you can see very similar picture. It's just that it becomes a high flow signal on the OCT angiography. And let's just try to show you the fly through here so you can compare next to each other on the OCTA on the left and the OCT en face on the right. Of course, here we can appreciate when we go down to the choroid, the Pachy vessels as well. What is a bit difficult is that when you have these lumps on the, or big round lesion rather, because it is a 2D, it is a compressed lesion, we can't actually know whether it is stereo or not nodular, as opposed to traditional ICGA. There is still controversy whether you are comfortable to call this, for example, these round lumps polypoidal, or some others. And some others, they call these simply a neovascular tangle or structure. So what we have found is that instead of using that if you look at may I ask everyone to try to mute because I'm getting some noises. Okay, so in addition to the en face, okay, to use the cross-sectional OCT, you can imagine this is where that sub-RP round lesion we could see just on the OCT is. And if you have a very localized flow signal within it, that's like bingo, that the three signs together, the cross-sectional OCT, the en face OCTA together with the cross-sectional OCTA with the flow signal on, gives you very high sensitivity and specificity. However, sometimes these lesions are very heterogeneous. So these are again many examples of how the cross-sectional OCT is very suggestive of the polypoidal lesion, and yet we know that sometimes you don't see that lighting up on the OCTA. As in these examples, it may be because of the blood, it may be because of the slow flow or turbulent flow. Many have proposed, but just to note that OCTA is great when you see it, but it's not always there, and I wouldn't use that to exclude the diagnosis of PCV. So here is another example showing multiple polypoidal lesions, and even within one single complex, you will have different types of signals. For example, the signal is much clearer in number 2 and number 3 and number 4, but less so in number 1. So again, it may be related to the dynamic flow properties of each individual polypoidal lesion. So again, here, the flow signals are not so obvious, whereas the cross-sectional OCT is highly suggestive of PCV already. So Jay has already mentioned that particularly with OCTA, it is useful to screen out the kind of asymptomatic neovascularization, and sometimes they can have polypoidal within that MNV as well, particularly in the fellow eye. So this is one example of MNV type 1 in the fellow eye, and sometimes they can have a bump there, which shows that within that big MNV type 1, there is a polypoidal lesion as well. And these are non-exudative lesions described in multiple series in the fellow eyes, as Jay has mentioned, and we have published about 1 in 5 of our patients presenting with first eye CNV or PCV can harbor one of these lesions. Okay, this is a shallow irregular PED, but sometimes they can be much more bumpy like this, and you would highly suspect PCV. And indeed, there is no fluid, so we don't want to subject this eye to an invasive angiography. So you can see the OCT angiography is like really beautiful. Within like 5 seconds, you got the diagnosis. What is very interesting is that these two are actually not different eyes. This is the same eye which we followed up over the years, and you can see how it evolves from what appears to be a type 1 MNV slowly into a PCV. So that's another very interesting area. Another limitations I want to very quickly mention about OCTA is that it showed the structure of that lesion very beautifully. if I go back one, that lesion just now was so aggressive looking, and you would not have imagined that it was non-exudative, right? Okay, but there is no fluid. It's sitting there quietly. And here, this lesion slowly developed a little bit of intraretinal fluid. And you only can tell that exudative activity by the structural OCT. When you look at the OCT angio, really there is no significant difference in there. So there is still a lot of controversy about looking at the OCT angio to tell you whether a lesion is active or not. And I think so far we're not really ready to make that call. So very final couple of minutes is, what about ICGA? We can't talk about imaging PCV without talking about ICGA, and that really is still the gold standard, and we're familiar with the signs on ICGA. And in this case, for example, you could have told that there is a polyp there with the non-invasive signs that I've shown you earlier on. So what does the ICGA add? And here you can see the ICGA marked choroidal hyperpermeability, not only in the PCVI, but also in the fellow eyes. Another example, again, is in the late ICG. So I think with ICG, we don't simply stop at the level of diagnosing the presence or absence of the PCV, but there is so much more that we don't understand. What is the choroidal background? There is overlap with what Jay's shown you about the central serous spectrum or the pachychoroid spectrum. So we still need to use a lot of these multimodal imaging to improve our current understanding of PCV. So with that, I would just conclude. I've gone through the three modalities, non-ICGA diagnostic criteria. I think that gives you a practical help in daily practice. OCTA is something new and exciting. All of us love to play with it. There are some limitations. And finally, don't forget our old friend ICGA as well. Thank you again for giving me the opportunity to share here.
That was great, Jamie. So let's hear Adrian, and then we can take some questions after Adrian's talk. Adrian, the floor is all yours.
Yeah.
Good morning and hello from Singapore. Thank you, Lite. And of course, a big thank you to Francisco. Thank you very much for inviting me to this webinar. I've been meaning to visit Colombia for a long time, and this is one opportunity to do so virtually. And I hope one day I will be able to make it after all. I would like to spend the next few minutes talking about our treatment options, especially what the evidence shows for polypoidal choroidal vasculopathy. These are my financial disclosures. If you look at what the current level 1 evidence shows, you can see on the one hand, a few that have looked at combination therapy, which is verteporfin photodynamic therapy with an anti-VEGF agent. And Everest 1 and 2 studies were pivotal with that. Also the Fujisan study, which was a deferred PDT with ranibizumab. And on the right, you see monotherapy trials.
Adrian, we don't see your presentation. We see just one image.
Okay, let me restart that. Do you see it now?
No, we don't see it.
Sorry, let me start again. Do you see it now?
Yes.
Sorry about
Yes.
that. Sorry about that. Okay, so I'll start again. The combination, as you can see, the therapies that have tried combination therapy on the left, and then monotherapy, most notably the PLANET study on the right. DRAGON was a study that originated in China. So the key question which most people are interested in is, which do we choose? Is anti-VEGF monotherapy superior to combination therapy, or the other way around? Which one is better? Well, let's first deal with the evidence surrounding anti-VEGF monotherapy. And I think the most important trial that answers some of these questions was the PLANET study. As you know, 310 patients, they were initially given 3 doses of aflibercept, and at week 12, they were randomized into those that were eligible for PDT and those who received sham PDT. Remember that many of those patients on the left, which were eligible for active PDT, did not actually go on to receive it because the criteria for rescue PDT was actually set quite stringently high. So you see, for example, visual acuity had to be 612, and there was a change in visual acuity for the worse, as well as new and persistent fluid. And then finally, of course, you had to show the presence of active polyps on ICG before one could go on to receive rescue PDT. But the results were actually quite impressive. You see, on average, a 10-letter gain at the end of 52 and also at 96 weeks with both groups. Essentially, if you think about it, even in the PDT eligible group, the majority of patients did not receive PDT. So in effect, these 2 groups were really aflibercept monotherapy results. You see a very nice drying of the macula very early on, within 2 months, and it's maintained right through to the study. The problem, of course, is that you have to continue to keep up with these treatments. In the first year, it was a fixed dosing, first 3 monthly doses, followed by 2 monthly. In the second year, it was on a treat and extend basis, but you still end up with about 13 injections of aflibercept over 2 years. And of course, we've got newer agents that have now been available, the most recent being brolucizumab or Beovu. We did an analysis of the patients in Japan in the Hawk and Harrier trial who had ICG-proven presence of polypoidal. And you're, I think, mostly familiar with the study design of Hawk, and I will not go through this, but you'll see that clearly there were almost 60% of patients with the polypoidal in the Hawk group among Japanese patients. This is quite substantial, and it reflects also the ethnic distribution of polypoidal. But interestingly, you see that all 3 groups, brolucizumab 3 and 6 milligrams, as well as aflibercept, had good results with visual acuity. There was no statistical difference. You can see very similar results, 10 letters gain at 48 weeks for brolucizumab 6 milligrams, compared to aflibercept of 11.6 letters. What's interesting also is the potential for a slightly longer dosing interval with brolucizumab. This is the hope that we're trying to find longer acting agents. And you'll find that almost 70% of patients on brolucizumab could be maintained on Q12 dosing interval immediately following loading. So this is quite promising. And you see very nicely reflected also reduction in the central subfield from fluid, very effective with brolucizumab as it was with aflibercept. But what's impressive here is really the reduction of fluid. So the drying effect of brolucizumab here is shown against aflibercept. If you look at week 48, for example, there were very, very small numbers of patients treated with brolucizumab with persistent fluid, 7.7%, compared to 30% with aflibercept. What's also impressive was the effect on sub-RPE fluid. Many of you would agree with me that sub-RPE fluid sometimes is very resistant to control, but here brolucizumab seems to have a superior effect on sub-RPE fluid. So certainly something to look out for. We are in fact in the midst of planning a randomized multi-center controlled trial for polypoidal specifically using brolucizumab. But having said that, I think there still remains significant limitations to anti-VEGF monotherapy, regardless of which agent you use. The first is, of course, the number of injections and frequency. The next is what happens when you stop the anti-VEGF. High recurrence rates have been reported. Almost 50% to 60% may well be non-responders to anti-VEGF, depending on the agent. Polypoidal lesions often persist despite being able to inactivate these polyps. And the problem with these polyps, of course, is that they may lead ultimately to massive hemorrhage. This is a typical case illustrating the need for frequent injections. Note that the fluid never really goes away even after 12 consecutive monthly ranibizumab injections. This is a nice study from Turkey that showed that 56% of patients who did not show good response after initial 3 ranibizumab injections actually had underlying polypoidal. Interestingly, related to Jay's talk, 26.5 actually had chronic CSC. And finally, I want to talk about the concept of closure of these lesions. Do we need to actually destroy them? Do we need to occlude them completely? Or is it sufficient just to inactivate them even if they persist? Now, the evidence from Planet suggests that if you can just inactivate these polyps, that means stop them from leaking, even if they are still seen or present on the ICG, that's enough. As long as you've got anti-VEGF cover. Here you see at 52 weeks, almost 90% of these polyps were no longer active, and this was maintained through the second year. However, actually only a third of patients treated with aflibercept had complete polyp regression, and this is quite surprising. And what happens really sometimes if you end up with a nasty surprise? These persistent polyps can lead to massive hemorrhage like this. And in a Korean study with Cho, after about 9 years, about 40% of patients who still had these persistent polyps developed massive hemorrhage. A case in point is in this patient in the Planet study who did very well while he was receiving aflibercept. But 4 months after the trial ended, he then developed massive hemorrhage and never recovered vision after that. These are other examples where patients who are on regular anti-VEGF treatment continue to show a potential breakthrough with massive hemorrhage and poor vision. And so that's why we start also examining whether there are many better ways of handling these sometimes complex problems. We were, of course, disappointed with the results of Mont Blanc for choroidal neovascularization using combination therapy. And so largely combination therapy had dropped out of the scene when talking about neovascular AMD. But I think Everest 1 and Everest 2 in particular showed that there is still a role for adding PDT to an anti-VEGF. Here you see in Everest 2, in the combination arm in blue, a superior benefit of visual acuity gains compared to ranibizumab alone, 10 letters versus 5.6 letters, and this was statistically significant. What I want to emphasize here is the polyp regression. Remember I mentioned inactive polyps versus actual closure of the polyps. With combination therapy, particularly the effect of photodynamic therapy, you have a much higher possibility of closing these polyps down, at least temporarily. So 70% after month 12 with combination compared to 34% with monotherapy. And a similar result that we expect to see a more drying effect with the combination. Almost 70% of patients by month 12 have no fluid at all. That includes sub-RPE fluid in the combination arm. Now, how long does this last? Of course, the trial only lasted 2 years. But if you look at the analysis, the time to first recurrence of disease activity was actually quite long, a median of 183 days, effectively 6 months in the combination therapy compared to 2 months with the monotherapy. So in other words, if you start off with combination therapy, you end up with a slightly longer disease-free interval and perhaps more importantly, a reduced number of treatments. So you see over 12 months, the median injections was 4. In effect, these patients required first 3 loading doses and 1 additional ranibizumab over the remaining months compared to ranibizumab alone, which was 7 injections. If you see the spread, what's also impressive is that in the ranibizumab only arm, 20% required almost monthly injections over 2 years. This is very reflective of this persistent activity, even if they are responsive. What was also gratifying to see was that the number of PDT injections was very low, on average 1 and at most 2. Now, why am I saying that combination therapy might work for PCV and not for CNV? Well, there are major differences between the two diseases. You heard a very elegant comparison of all the important features from Jemmy. But PCV is essentially bi-component. You've got both the branching vascular network, which is similar to a CNV at some point, and then these terminal dilatations called polyps. Now, the PDT is shown to be more effective in closing these polyps down, which in my mind is still an important aim. And almost 30 to 60% of PCV cases can be refractory to anti-VEGF monotherapy. And PDT is the one factor that can decrease choroidal thickness. If you think about it, maybe choroidal thickness is reflective of the underlying disease pathology. And here very nicely showed PDT is more effective than aflibercept and ranibizumab in reducing choroidal thickness. We don't know where brolucizumab lies. It's probably between PDT and aflibercept. Now, why do we want to avoid repeated multiple PDTs? Because of the risk of atrophy. And this is a very nice paper from Fumigomi, Japan, showing the progressive atrophy with repeated PDT and, of course, loss of vision. And therefore, we've learned also from Everest 2 that if these polyps recur, we do not need to treat the entire lesion again. That is, only target the active polyps. This way, you can keep the spot size really small. This is an example of a case from Korea where the recurrence actually originated in the area marked with the blue arrows, and that was the region that was treated with PDT alone. Now, sometimes you can have recurrence without polyps, so it's really important to be sure, because if there are no polyps, there's really no point in applying PDT again. These are patients who only need anti-VEGF and not combination. So I believe that the best of both worlds can be met with PDTs, mainly for the polyp closure. Anti-VEGF is really good for leakage. Now, is there a winner in this head-to-head? The answer is no, because both are excellent, both are backed by evidence, and both depends on the clinical situation. But there are some examples where I would not advise combination therapy because you might end up with a poorer outcome. The first is initial vision. Most of our trials started with 6/12 or worse vision. So as long as the vision is 6/9 or better, there's actually no reason to use combination therapy unless you have tried monotherapy without success. We also find that small, single, non-pulsatile polyps are likely to close either on their own or just with anti-VEGF alone. So there's really no need for PDT. When there's a pre-existing thinning of the choroid or existing RPE atrophy, be very careful because PDT can cause more damage. Very large lesion size, in particular more than 4 millimeters in diameter, should not be treated with combination. Sometimes the activity, you're not sure whether it's polypoidal or whether it's coming from the branching vascular network. Err on the side of caution, start off with anti-VEGF. And lastly, massive submacular hemorrhage, because it obscures all your imaging. But remember that you can always add PDT later. I'll end up with a case, a 69-year-old female, initially treated with monotherapy ranibizumab. You see a single polyp, 6/6 vision, so 3 injections of ranibizumab, no response, indeed an increase in fluid, and an increase in the size of the polypoidal complex. After 6 months, the patient still does not improve. You see visual acuity starting to drop to 6/24, and then I add PDT to this ranibizumab, and the lesion then starts to quieten and remains so after about a year. So I think a universal approach should be taken. It's balanced with looking at accessibility, availability of ICG as well as PDT. So let's say you have a low-risk population where, say, polypoidal doesn't exceed 20% of all neovascular AMD. Then I think you can go ahead and treat as if any typical neovascular AMD. If there are no suspicious features, and you've heard from Jemmy what those are, then start off with anti-VEGF monotherapy. I think it's reasonable. If there is no response after 3 injections, get an ICG and then add PDT if necessary. But for many of us in Southeast Asia and East Asia, where there is a high risk of the probability of polypoidal, at least 50–60% of our patients, then most of us would require an ICG at baseline. Maybe with time, ICG may become redundant after we are comfortable with all the other multimodal imaging modalities. if it is present, we can still choose. We don't need to start with combination. We could start with monotherapy, but always remember that if you're not getting a response, add PDT. Combination does work and is safe. So to summarize, there is robust evidence that demonstrates the efficacy and safety of both. Both modalities are good, combination, as well as anti-VEGF monotherapy. But what's important is that if you have non-response, you should add PDT when it's required. And in our hands, combination therapy has been shown to have advantages. It achieves a higher rate of regression, higher rates of macular drying with no disease activity, longer treatment-free intervals, and a reduced injection burden. And all these factors perhaps would make me tip towards combination as my preferred choice. And once again, I want to thank the Colombian Retina Society, in particular Francisco, for inviting me to this excellent webinar. Thank you very much.
Great, Adrian. So we just had a great number of talks by experts in the field, and I'm going to open the floor for some questions. So there's one question for Jay regarding your masquerades. How do you treat dome-shaped macula? Jay, are you there?
Oh, I'm sorry. I had muted myself. Yeah.
Okay.
Yeah. So can you hear me now?
Yes.
Yes.
Yeah. So I think dome-shaped macula is one of the challenging diagnoses to make and as well as to treat. So we have looked at dome-shaped macula cases with subretinal fluid for almost 2 to 3 years of follow-up, and they do not respond to anything. I have tried PDT, eplerenone, micropulse laser, almost nothing works. So I believe that no treatment is still able to resolve the fluid. But I said before that, very fortunately, these patients usually maintain a very good visual acuity even for the long term. So you should not be worrying. However, it is very, very important to keep looking for a CNV, because it is very high chances to have a CNV with the dome-shaped macula. That requires anti-VEGF anyways, and possibly PDT if needed.
Any other thoughts, Adrian or Jemmy, regarding?
Yes, Lite, I just want to add that I've been disappointed with the effect of combination therapy, and sometimes it is impossible to completely eliminate subretinal fluid. So I often guide treatment based on the visual symptoms after that. Of course, the initial therapy, I would try an anti-VEGF, but it's been universally disappointing. I'm not sure what the others think.
Just to add that sometimes the fluid comes and goes as well. So I've seen spontaneous resolution. So I tell patients that sometimes we try all sorts of modalities and the fluid goes and we assume it is the treatment that we gave, but sometimes actually it's just luck.
Right.
I think if I've tried PDT once or twice and it doesn't work, I really do not proceed further, because really I think the treatment may be worse than the disease. So I think in such instances, we shouldn't chase with too many PDTs.
So Jamie, why are the vessels in Sattler's layer dilated in PCV? Why does that happen? Do you know?
Please tell us.
I don't think I have the answer. Jay is like,
I thought you would answer.
There are multiple proposed theories at the moment. It could be a outflow congestion. It could be some chemicals, like for example, in the case of central serous, whether it's something to do with the cortisol levels, etc. But no, I would be very happy to look for the underlying cause. Maybe Jay and Adrian can add to that.
Yeah, you know, some of these questions you are always scared that you will be asked when you yourself don't know the answer. This is one of them, and the next is coming for me. It's already in the chat box.
I wish we knew. I mean, it's still a big unknown. We have all these theories, obviously, but if we can find the reason why the choroid is thickened, why there's choroidal hyperpermeability, we will have made a significant step towards solving these problems.
So Adrian, regarding the treatment, is there any difference whether or not the the choroid is thickened or not when you treat with anti-VEGF in terms of the outcomes?
Certainly. I think if you have thick choroids, especially if you see ICG hyperpermeability, the results of combination therapy are much better than anti-VEGF monotherapy. But the moment you start to see a thin choroid, in fact, combination might make it worse because of more progressive atrophy induced by PDT. When the choroid is thin, I try and avoid PDT if I can. If I can't, I will start off with a reduced fluence or half dose PDT.
Any role for thermal laser in PCV?
Particularly, I think in recurrent disease, some of the examples I showed, with the primary treatment, most times you want to catch the branching vascular network together with the polyp, and very often they go across the fovea. So you may not have a choice. You might have to do PDT. But with recurrent disease, because you don't want to target the BVN, only the specific active polyps, very often these polyps may be in an extrafoveal position. They are amenable to very light focal laser. I also saw in the question panel, some people asked about micropulse. Unfortunately, I don't have much experience, and I think the literature does not support micropulse just at the moment. Perhaps for some groups of physicians who have experience with micropulse, this would be a very nice head-to-head, the combination using PDT versus a combination using micropulse with an anti-VEGF, and that will be very, very helpful for the rest of the world.
I have tried for one of my patients back in India using micropulse because the patient couldn't afford PDT. But honestly, I did not had good experience. It did not make any difference.
And Jay, how do you differentiate a neovascular membrane secondary to central serous from the pachychoroid neovasculopathy?
Pass. Honestly, this fight of pachychoroid, I thought Jamie will be, this question will be asked to Jamie, but yeah. But I think there is always a challenge, you know, that we still are unsure whether CSR is a separate entity or it actually should fall in the pachychoroid. And does actually the PNV, the pachychoroid neovasculopathy, is CSR associated neovascles? We still don't have much answer. However, one thing I can clearly say that it is still possible to have CSR and have CSR related CNVM even when you do not have a very obvious features of pachychoroid such as inner choroid loss and choriocapillaris loss. There is still a possibility. Jamie and Adrian, any thoughts?
I agree with you, Jay. I think anything to do with the word pachychoroid currently is quite controversial, partly because we can't actually define the disease very well. Having said that, there are some features that we do feel quite strongly about, such as a thickened choroid, the dilated Haller's vessels, and the ICGA hyperpermeability. Those are definitely some features that we see in certain eyes. And like Adrian said, if we can crack that, it can really help us plan how we're going to treat these eyes differently.
My views on this definition of pachychoroid spectrum is that they are all describing phenotypes, not really underlying disease. So when I describe a phenotype of central serous, I want to make sure there is no underlying neovascularization. The moment I see any hint of neovascularization, I will call it pachychoroid neovasculopathy. So that way it helps me to separate the two. But this is an artificial, arbitrary separation nonetheless. So I don't distinguish the two.
Okay, good. And a question, would you completely remove eplerenone from your armamentarium for the treatment of chronic CSER without CMVM after the results of the VC trial? Jay, thoughts?
I have been using eplerenone for almost now 3.5 to 4 years, and I have had really a long-term follow-up of many patients. And we started when we knew nothing. We still did not have any. We still do not have any specific protocols. I would say that the overall experience has been mixed. I would not remove it from the armamentarium. In fact, here in the US as well, I have started 2 of my patients on eplerenone, though the VC trial has showed the poor outcome. I would not remove. Yes, some patients respond, some patients don't respond. what defines the treatment response, we still do not know.
And what is the experience in Singapore?
Sorry?
What is the experience in Singapore, Adrian and Jamie, with eplerenone?
So maybe I'll start by saying that I think the results in Caucasian patients may be better than in the Oriental or East Asians. I'm not sure about in South America, and it'll be interesting to compare. My response rate to eplerenone for acute CSC is only about 30%. And because these are young individuals, many of them actually have quite debilitating side effects, cramp, one of them, fatigue, and so on. So it is not something that I take lightly, and very often I discuss with patients. So in acute CSC, my first line is eplerenone. We try it first, and if the patient is able to tolerate, whether or not it reduces the disease activity, I'm not sure, but I would try that, and it's therefore still an important place in armamentarium. Now with chronic CSC, I think we still have to stop those leaks, and eplerenone is not effective at reducing choroidal vascularity and congestion. So I feel that in chronic CSC, as an adjunct, maybe, but certainly not as primary treatment.
Jamie, you agree?
Yeah, I agree. My experience similar to what Jay has described, and I would still keep that as an option. Certainly, I've had cases that has been sitting on that neurosensory detachment for months and months, and within starting eplerenone, it just goes within a month. But I know with the Vichy trial results, so I think the main thing is to have proper patient counseling, like Adrian say, that it is still pretty much experimental or unproven treatment. There may be some side effects, but it is relatively easy to pop a pill and try.
And switching gears here, is brolucizumab available in Singapore at this point?
No, not yet.
And what are your thoughts on the severe inflammation, vasculitis that has been reported by the ASRS, etc.? Is that something that concerns you? Jay, you're probably in Pittsburgh, so you probably have access to it. Have you used brolucizumab?
So I was about to give my first brolucizumab, and I came back from Macular Society and I deferred that. because listening from Rick Spade and Bailey, I realized they had some patients who had the inflammation, and Rick had vision loss after injection. So I was about to inject a one-eyed patient. So I said, okay, let's work with Eylea for a while. And yeah. So far I've been fortunate not to have any inflammation because I did not use it.
Very good. So one last question here is for you, Jay. And it says, any predictor an OCT for the eplerenone response?
This is an interesting question, and when I was in India, we were using a lot of eplerenone. We in fact published the paper where we actually showed, and like the way Jamie was saying, that some of my patients, those who primarily had the cystic changes and the cystoid degenerative changes, these patients actually, they did really well. So I would say that there are no specific, because our study was also very small numbers with short follow-up. However, I would say that we still do not have any specific predictors. I'm still looking at the CVI component of it. I would say that I tend to give eplerenone if I see persistent subretinal fluid with cystic changes primarily.
Very good. I guess there are no other questions. So I will turn this over to Francisco. And I'd like to, for my part, to thank you all. It's great seeing you virtually, Adrian, Jay, Jamie. Until the next time.
Thank you very much, guys, for your participation and for agreeing to be with us in this webinar. Excellent presentations as always. Thank you very much.
Thank you so much.
Thank you all.
Have a good night and good morning. Thank you.
Take care.
Have a good morning,
safe, everyone.
Stay safe. Bye-bye.
Sorry to wake you up. Sorry to wake you up, Adrian.
It's a pleasure.
Thank you. Jimmy, thank you very much.
Thank you.
Take care.
Take care.
And be safe. Be safe.